Hello, everyone, and welcome to the first talk of the day, which is Treating Eating Disorders, Building Pattern and Reducing Prevalence. We've already had everybody introduced, so I think I'll just go straight on into it, if that's okay. I'll introduce myself really quickly. I'm Claudia Canavan. I'm the health editor of Women's Health magazine, and the rest of our panelists are up here on the board. We've got Rivki, Yoel, and Professor Rebecca. I'll start with a question that I'll put out to everybody, and if Rebecca, if you could answer first, that would be brilliant. Global prevalence of eating disorders is increasing. In the UK, hospital admissions for such illnesses have spiked 84% in the past 5 years. How does this reality link with the work that you are doing to explore the potential of psychedelic-assisted psychotherapy for anorexia nervosa?
Well, it's tragic. It's tragic, the increase in prevalence. But looking back, when I started opening an eating disorder therapeutic unit 20 years ago, when the prevalence was lower, we had better access to state-of-the-art psychotherapies because it wasn't so diluted. And yet I noticed that even with the best psychotherapies we had in Oxford, and Oxford does psychotherapy well, there's a lot of people, particularly with anorexia nervosa, particularly if they've been ill longer than 2 or 3 years, that we just weren't getting better. I thought, this is like treating schizophrenia without any medication, because there are no approved drugs for anorexia nervosa. There's drugs for the comorbidities. Even they don't work very well in people who are very underweight. So I guess I spent the next 20 years researching the mechanisms underlying the illness to think about what might help, and then intervening with things. We've been involved in deep brain stimulation on the compulsive circuits, but the psilocybin work was an opportunity to think more widely about something that could help unstick people that are very, very stuck, and an illness that costs a lot of lives and a lot of money. Yeah.
Thanks, Rebecca. Yoel, could you answer the question as well, please?
Yeah, sure. So I think that just as Rebecca stated, this illness is firstly a incredibly difficult illness to treat, and one that causes immense frustration and damage, of course, to the individuals themselves, to their families, to the communities, to health providers. So when considering the rationale for looking into this new indication, that definitely is something that is at the base of founding this clinical rationale to explore this. The reality is very, very dire. There are a lot of patients that are really desperate for good quality care, and the reality, as Rebecca mentioned, is that for many of them, we don't really have a lot to offer.
And Rivki, what are your thoughts, please?
I'd like to add that with the passion to bring forth a new way of treating patients, there's also, and I have to admit, economic consideration. We're a commercial company. We're sponsoring the Sheba trial for anorexia patients with psilocybin. And this field, unfortunately, as it has no FDA-approved medication, not even a standardized protocol of care, as far as I know, and the fact that it costs the US economy around $65 billion a year, eating disorders in general, in healthcare costs, direct and indirect. And the fact that the treatment for anorexia nervosa is currently taking place in the form of therapy, mostly, over a lengthy period of time, we actually see a potential for a commercial model for psilocybin assisted therapy or combination drug-assisted therapy in this field. And this is part of our sponsorship and pursuit of this category, of course, to heal and treat, but also to present a viable economic model in this industry, which is yet to be completely determined.
Let's touch on protocols briefly. So, Rebecca, you're an associate professor and honorary consultant psychiatrist at Oxford and a clinical researcher and expert in eating disorders. And you're also a visiting professor at the Centre for Psychedelic Research at Imperial. There you've been collaborating with the team on the study of psilocybin for anorexia nervosa. Could you tell us a bit about the protocol for that study, these studies?
Yeah, I mean, the protocol's published. It's very rigorous. My role within that team, and it's an amazing team, has been not in the guiding, not in the psychotherapy, but in the helping them choose the best patients, assess them safely, and then independently charting their eating disorder psychopathology over the course of 3-6 months. So that's been fascinating. The protocol includes a lot of screening, a medical screen, a therapeutic screen, and an involvement of a support person, all of which has to pass go in order for somebody to enter. And then they have a lot of preparation, intense guiding and integration after 3 sessions, 3 dosing sessions, one of which, at least one of which will be high dose. And that's what they're told. And then their progress is charted over the course of 6 weeks, 3 months, 6 months, with a remote follow-up at 12 months. And we've recruited 20 people and I think dosed 20. So preliminary results were presented at in Denver at the MAPS conference.
Thanks, Rebecca. And Yoel, you work obviously at the Sheba Medical Center, Israel Sheba Medical Center's Center for Eating Disorders. You're working on the phase 2 clinical trial, which is sponsored by the Shortwave Pharma team, looking into the safety and feasibility of psilocybin-assisted psychotherapy for anorexia nervosa. Psilocybin and MDMA-assisted therapy. Could you talk a bit about the protocols in these studies?
Yes, sure. So our protocol is also quite in line with a lot of what Rebecca just mentioned, realizing that firstly, this is a safety and feasibility study, but this is a patient population that requires a tremendous amount of support. So that means that we have 3 preparation and 3 integration sessions before and after each experimental sessions, in a total of 3 experimental sessions, whether it was MDMA or psilocybin. Also hoping to perhaps have a combined protocol come out as well with 2 MDMA sessions and a 3rd psilocybin session. Another thing that we thought to be very, very crucial was to have proper nutritional support for all participants. So that means that all of them, obviously, they also go through medical screening, psychiatric screening, looking into their support systems as well. And firstly, before getting them into the trial, making sure that they're all they meet the proper requirements. They have a weekly session throughout the duration of the trial with a clinical dietitian that also focuses mostly on, obviously, their diet, their eating habits, trying to promote motivation, trying to help them perhaps take on a bit of challenges, take on widening the spectrum of what it is that they allow themselves to eat, which is usually naturally very, very, very minuscule. That's basically the design with a follow-up as well as 3, 6, and 12 months, looking into hopefully positive indications.
Great, thank you. Let's talk about the possible mechanisms via which psychedelic-assisted psychotherapy might allow some people suffering with an eating disorder to experience some sort of relief. Rebecca, can we talk about this? Anything you've observed, anything that's coming out of preliminary data?
I think it's more important to think about what the underlying mechanisms with anorexia nervosa are neurally. And we've researched that for some time using imaging and experiments. So firstly, there is an aberrant reward element whereby people get initially a kick out of restriction. It's a coping mechanism that works for them, but then it got stuck, rather like an addiction, and there's a compulsivity element that then takes over, which people can't break free of. And what you see neurally when you do imaging is a very, very stuck system consistent with their rigid behaviors and thought patterns, a very stuck network. Resting state, or even if you prime the brain, it's very geared towards alert to high energy foods in a way that's not helpful. And the other profound thing which it makes is particularly unique about anorexia nervosa is there's a desync between what's felt in the body and the head. So, and the lower weight goes, the more out of sync people become with their bodies, which of course makes it fairly easy to starve to death, right? Mm-hmm. So our hope with psilocybin would be that some of these very stuck networks would be released, and in particular, my hope would be that people are able to be more embodied, more in touch with their bodies in a way that will allow them to start to recover.
Yoel, could you touch on that as well, please?
Yes, sure. Perhaps I'll say a bit more. So there is that aspect with psilocybin, I think specifically looking into interception, which is that a person's ability to really look inwards and understand and process signaling coming out of the body, which is something that is very damaged with anorectic patients. So that embodiment is a very, very crucial part of what we believe might be a very beneficial aspect of psilocybin for these patients. There also is the encouraging indications that this drastic change in brain connectivity and brain activity during the psilocybin sessions creates this window of neuroplasticity, reduction in rigidity, which is something that these patients are very, very, very characterized by. They have incredibly rigid thinking and rigid cognitive patterns. So, that smoothing of those paths perhaps opens up a window in which you can work with and leverage through therapy and through integration. That goes as well for ND, not necessarily through what might be the same neural mechanisms, and this is obviously yet to be explored and yet to be researched. But there you might expect a certain, its anxiety-reducing properties, its inducement of self-compassion and self-connection, its the ability, the rise in sociability to create a certain widening of we call it in psychedelic assisted psychotherapy, a certain widening of a window of tolerance in which patients have a better and more robust capacity for processing complex emotions, processing traumas. And again, that creates a certain window of opportunity in which you work with through therapy. So that, in a nutshell, what we are. Those are the indications.
Great. And can we talk about how you identify people for whom this treatment might be beneficial? Of course, nothing works for everyone. Rivki, would you be happy to touch on that, how the team is identifying people who might be suitable for this treatment?
I'll leave the inclusion and exclusion criteria to my learned scientists and psychologists. I can just say that there is obviously the dilemma in the sector of people having access to psychedelics. You know, where do you open the door and when do you shut it? When there is no FDA-approved medication for a disease, how do we best utilize this potentially potent and effective drug, but deny it to some of the population, allow it for others? It's something that I guess the evolution of the studies and the safety and the process that you both are undertaking in these studies will eventually allow a very knowledge-based and experience-based data to be able to differentiate who is able to access and who isn't. But it's a grander question, you know, how do we allow people who need a medication, or how do we say, no, you can't? But
yeah, Rebecca, could you touch on that? Could you say something about how you guard against people for whom this type of therapy might not be appropriate from accessing it, and how you bring in people who you think it might work for?
Well, firstly, there's the general contraindications for all clinical psilocybin studies, like history of psychosis or family history of psychosis or severe suicidality. But there's additional things for anorexia nervosa which are particularly important. This is the disorder with the highest medical risk of any psychiatric disorder. So somebody must be medically stable. Although they may be low weight, they must be stably low weight and safe. in that place. But also particularly the psychological fragility of somebody who's been ill since they were 11, 12, 13, maybe been in and out of. So somebody needs to be robust enough in themselves to withstand what's quite an intense experience, and to be held. And our study is alongside treatment as usual, which in the NHS is not always optimal. So it's kind of, it's thinking, how is this person got enough in their lives to go back to if it works? And if it doesn't work, are they robust enough to withstand the disappointment? Mm-hmm. Yeah, because we can raise our hopes, and if we dash hopes in somebody who is already pretty hopeless, that's really hard. So it's, yeah, I hope that answers the question.
Mm-hmm. Yoel, do you have anything to add to that?
Yeah, sure. I'm just nodding in agreement with basically everything that's being said here. I think another important thing to note, especially when focusing on anorexia patients are usually described as incredibly ambivalent and resistant to treatment. They don't usually seek out treatment, and if they do, it's usually been coerced by their partners and by their families. And I'm saying this because an important aspect is motivation, and that's something that it's a bit paradoxical when working with anorexia. Many of these patients, as I've said, they don't really seek treatment, but this type of intervention, at least as it is designed at the moment, requires robustness, requires patients that are on board, and that by itself many times is 90% of the process when working with anorectic patients. It's not getting them through the door to the therapy center, but it is getting them on board, and many times that takes 2 or 3 or 4 inpatient rounds for that to happen, if at all. So one of the things that are crucial is that this type of intervention needs people to be willing and wanting to change. And how do we induce that? Well, that's something that we're going to have to keep on thinking and researching and trying to figure better ways to create that platform for them to then go into treatment.
I think one thing that's really important is that the individual trusts the process, trusts the people that their care. Many of them have had care which has not been a great experience for them. But so it's really important that they trust their care team. Yeah.
That leads on to questions on safety concerns. So as we all know, people with eating disorders are highly vulnerable, and especially, as you've mentioned, Rebecca, people who are coming to this treatment because nothing else has worked. What does longer term post-trial care look like for these people? I'm thinking, as you mentioned, those for whom the treatment doesn't work and they're incredibly disappointed, or those who have experiences that they find hard to integrate.
Well, there's an ideal and there's a reality. The reality is that at the moment, psilocybin isn't available after a trial. We in Imperial will do our best to remotely be there, but these individuals are under a different clinical team, and that rests on the availability of that clinical team. The ideal would be to have a protocol where somebody does have ongoing, continuous therapeutic follow-up in some sort of that's signed it up for by the provider, the care provider, or a model where you combine a structured therapy and evidence-based therapy with that window of opportunity, so that you can mold the right changes and help people practice them in a way they feel safe. Mm-hmm. That would be the ideal, and I would say, yeah.
If I can just add that, because anorexia is such a chronic condition, so in terms of insurers and providers, there is all the common sense in the world to continue with psilocybin-based or psychedelic-based medicine over a period of time in different doses, but to overcome the chronicity, it costs the economy more, as is today, and it will definitely have economic value.
Yeah, I agree. If one of the findings would be that we managed to lower inpatient admissions, because perhaps this therapy can offer a path in which patients have received care that allows them to later be more motivated and more robust to carry on treatment by themselves. That definitely will have a great economic impact, and hopefully that's something we might see in the future. I think, and I also agree, us being a center for eating disorders coming out of Sheba Medical, that is something that we also put in our protocol, where follow-up is something that is offered to the participants, not only follow-up in the sense of the clinical trial and looking into how it is that they're going, but continued care in our center for those that will be interested in that, of course, depending on the professional's discretion. Yeah, so
Great.
just something I wanted to add.
Sure. And are there any limitations to this type of therapy that we need to be aware of? Anyone, we've mentioned people who might not be able to receive it as a result of a history of certain psychiatric conditions. Are there any other limitations we should be aware of?
Well, remember that most of these studies are just, they're preliminary. They're sort of safety, tolerability, acceptability with initial sort of efficacy. So we're early days in there. And I think there's a lot of ways that things could go wrong if people aren't sort of supported afterwards or helped. They could have a bad trip. They could have a nasty experience which would make them retreat right back into their eating disorder. So it's early days. We need to be cautious. Cautiously optimistic, but cautious, yeah.
Sure. Yoel, have you got anything to add?
Well, it was discussed a bit just now that one of the characteristics of anorexia and eating disorders in general is that it is a maladaptive coping mechanism. So it is maladaptive, but it is a coping mechanism. And there is a risk when you strip people of their coping mechanisms too quickly without offering anything to replace that. Then you're definitely in uncharted territory and in dangerous waters. And that means that there is a risk, obviously there's a risk of relapse, there's a risk of developing other eating disorder symptoms, and there's a risk of people breaking down. So the limitation would be to keep that in mind when carrying this on forward is something that always needs to pay a lot of attention to the support system and the therapy and the framework around this intervention. Yeah.
Great. And Rebecca, as you mentioned, very early days for everybody's research, but is there anything you want to flag that's coming out of early data, anything exciting, anything anybody wants to speak about?
Well, I think I can say that I was pleasantly surprised to chart the eating disorder symptoms of these folk in our study, very pleasantly surprised. And that will be published soon, but cautiously but pleasantly surprised. But this is one study and with a lot of therapeutic input, so yeah.
Rivki, is there anything you'd like to talk about?
We're developing a novel product, so we're going the full preclinical route. Currently undergoing safety with preliminary results and preparing for our efficacy studies, which I believe have not been common in the field of psychedelics and anorexia specifically. We're preparing for an ABA model efficacy study. ABA is activity-based anorexia. It's a way of inducing anorexia symptoms and behaviors in rodents, in our case. And it's amazingly one of the best animal models for mental health. And we expect to have some very interesting findings specifically on our product and on the efficacy, of course, safety and other criteria that will define the way that it is administered and dosing and everything going forward. So very early days before the early days of clinical testing and then early days for the drug itself and its commercial path, but sure, we have to do it.
Yoel, anything to add to that?
Well, our trial just got off the ground. I can't phrase it as data, but I can say I am excited, and I think for a good reason. So that's something that I feel that is, with caution, which I feel as perhaps as clinicians and as researchers, we always emphasize, and it definitely continue to emphasize, but it is exciting. It's exciting times. There are things to be excited about.
Cool. Well, that leads me neatly onto the last question, which is, let's all wrap up with each of you sharing one hope and one concern about how this work might play out over the next, let's say, 5 years. What are you all optimistic about, and what worries you when it comes to this research and its real-world application? Rebecca, would you like to start?
Well, my hope would be that there's enough funding for decently sort of funded and organised and designed studies to get really good quality data without rushing through to some miracle cure, which for anorexia nervosa doesn't happen. Sure. You know, that would be my hope. I suppose my fear is that if things are rushed through too quickly, there will be adverse results coming out of poorly designed studies, which will knock it all on the head. Mm-hmm. Yeah.
Rivki, would you like to go next?
Well, Rebecca's hope is my concern, that there's enough funding to pull through this long process. I think time is our main adversary and a helper. Hopefully, we can make some leaps with good data and good studies.
Yoel?
I think it's going to be a very interesting next few years coming up in the field. Interesting research, interesting therapy protocols. Of course, there always is the concern of funding. That's always a struggle. These are very complicated trials to bring off the ground. They're very labor intensive, and that is always something that is always the concern. And I think I'd share perhaps a personal concern. Circling back perhaps to your first question, which is, well, what happens when the hype dies down? So we see these patients when the hype dies down, whether it's any hype. And we understand that it's a process. It's a long and winding road. You need to go into it knowing that there will be setbacks, there will be downfalls, there will be disappointment involved. But they need us to be there. They need us to know that we're going to follow through. So I think that's something that's important to keep in mind, perhaps a personal concern of mine.
I just like to add that funding and time and data, but also regulation. So if there are any regulators out there, help us get to this solution.
Help us get psilocybin into Israel.
Well, thank you so much, everyone, for joining us today. And thank you so much to Rivki, Yoel, and Rebecca for sharing their expertise. Thank you.
Thank you.